There are some patients who will break everything you put in them. They do.
Yeah.
They break everything. They will break porcelain, or they'll break abutments, or they'll break screws, or they'll break implants. They'll just break stuff. There are some patients who are just destructive.
Okay, great. So thank you for joining me on the next dental implant podcast. As you can tell, it's a little bit later on in the evening because I've got my nice comfy clothes on, which I'm known for. I much prefer to sit in comfort than anything else. Thank you to everybody who's been giving me feedback with regards to what you'd like to listen to, and it's giving me a lot of content moving forward as well. I'm very happy to have Bill Schaeffer joining me today. I have known Bill for quite a few years. I even went down to his practice, which is absolutely stunning. Bill, what you've built there is just absolutely incredible, and thank you for letting me come down all those many years ago. Bill is a dual qualified dentist and doctor. And Bill, am I correct in saying you're a specialist oral surgeon? Is that correct?
Yeah, that's right.
Yeah. So for those of you who know Bill, I've mentioned this a number of times, Bill's an absolute gentleman. He will highlight his own complications. I have never known Bill I've never known Bill to ever belittle anybody. He's just fantastic to learn from. So I'm hoping to get a lot of information today, and then I'll be picking up on a few things as well. So Bill, one of the main reasons I've asked you to come on today is just go over your experience with regards to Morse taper connections and short implants. If I've missed anything with regards to your bio, please feel free to add in there as well.
Bio's fine. People can look me up on Google or whatever. The bios. I place implants. That's it. I was lucky in that the dentist that got me started placing implants 25 years ago this year was using Bicon implants. So not knowing anything about dental implants, I started using Bicon implants. And it's a great little system. It's got a Morse taper. In fact, it's got a proper Morse taper, a proper locking taper. There are no screws. The abutment taps into the implant. And I kind of, for a long while, thought that was pretty normal for implants. For me, I've always probed around my implants. I've always expected that when I take an abutment off, there won't be a nasty smell. And that was just normal for me for years and years and years. I didn't place a different type of implant for 10 years after, for 10 years after that, when I placed my first ankylos implant. And we've been placing ankylos implant now for 15 years. Ankylos and Bicon share a lot of similarities. They've got a deep, steep internal taper. I don't really like calling it a Morse taper because that's a very specific engineering term. But it's got a deep, steep taper, which means that it seals the inside from the outside of the implant very well. I've placed a whole load of different implants. I've placed deep, steep tapered implants. I've placed external Xhex implants. I've placed all kinds of different things. I've been sent other people's cases with other people's implants to sort out. Everyone gets those, don't you? My crown's come loose, or this has happened, and we all get to sort those out. Sometimes you take off an abutment and it whiffs, it's smelly, it stinks. You get patients who kind of suck on their implant and they can taste something's not quite right. They get that odor. And I can honestly say that with a deep, steep tapered implant, you just never get that at all. I can bury my implants way down deep under the bone, way down deep, without worrying that the bone's instantly going to follow. Now, do you always need to place things deep? No. Sometimes you can't place things deep. Sometimes you have to place it at the level of the bone. But sometimes you've got a bony crest that's sloping. So then what do? Do you build up the slope that's low by vertical augmentation? That's just hard work. Do you place the implant too shallow on one side or too deep on the other side? It's no win. And if you have an implant system that has a tendency to lose bone to the connection, if you place it below the level of the bone, then that just means that you can't place it below the level of the bone easily. So for me, I've always steered towards internal steep, deep conical connections, whether it's Astro, whether it's Megagen, AnyRidge, whether it's Bicon, whether it's Anklos. To be honest, I mainly use Anklos.
Yeah.
But for me, I'm also very, very much of the opinion that all implants work if you know how to use them and you have a bit of luck.
Yeah, I mean, I think a very important point that you've highlighted already is a lot of different implant systems work very nicely. One of the reasons why I've moved to Xhex at the moment is I'm doing a lot of full arch work. And for me to get that internal correction with a southern coaxis, it means it's chewing up less into the prosthetic height because I can use a straight multi-unit abutment.
Completely.
I think Xhex gets a bad rep because a lot of people don't understand how to use it properly. And historically, they're talking about the abutments coming loose over time. Now, an issue with that is a lot of those older studies, they're based upon UCLA abutments which don't fit as well. And what we know is if you get a super precise fitting interface and you torque that Xhex up really nice and tight, you actually get a very stable connection. Now, I'm not saying that you're never going to have problems with it, but what I am trying to express is, as with a deep, steep internal connection, there's a way of using the implant. The same is true for an external hex as well. There's a certain way of using it, and a lot of people aren't aware of those nuances and start to run into trouble. So, Bill, if you wouldn't mind, could you go over some of the nuances of using the deep, steep internal connections?
So there are some things about them that are just glorious and some things that are a bit of a pain in the butt. The glorious bit is when I'm using one of these type of implants, I never, ever take an X-ray to see if my impression post is fully seated, because it always seats. It never crosses my mind that it doesn't. Whereas when I was trying to restore my Noble Speedy external hex implants, you had to take an X-ray to check, to verify that the impression coping was down. There are some things that are glorious. The pain can be if you're doing a two-stage implant. As with any implant, you can get bone right over the top, but you're more likely to if you are burying the implant deeper. When you fit a healing abutment, a sulcus form, or whatever you want to call it, you have it starting from a narrow emergence and then flaring out to get to your molar or premolar size diameter. And if your implant is buried deep, you have to contour the bone above it. And most of the time, if you're only burying the implant 1 millimeter or 2 millimeter deep, it's not an issue. But sometimes where you've got that real sloping ridge, the premolar region in uppers, where it slopes right up to the sinus, then sometimes you've got to take a big round burr and dig into that lovely bone that you don't want to remove in order to make sure that your components seat without binding. I saw we were both commenting on a case on an international website about an Anklos implant that lost bone, and who knows what the reason was, but I suspect that the healing cap was making ischemic necrosis on the bone.
Yeah, I remember that case actually. As soon as you pointed it out, I was like, actually, yeah, you know what? If you looked at that healing abutment, it was right on the crest. One of the things that I've noticed, because I have worked in practices where they have been placing Anklos for a very, very long time, is the bone levels tend to be extremely stable. I've seen, not my cases, because I haven't been placing this long, but I've seen cases which have got stable bone levels after 15 years. And that's obviously what you want from an implant system. And I think as well as that deep, steep internal connection, that you get the automatic platform switch with that as well. But when you place it deep as well, Bill, you get this really nice, it's like a long soft tissue connection going right down to the neck of the implant. So you get that really nice thickness of soft tissue around it as well. Would you agree with that? That's one of the parameters that helps with the stability.
I agree with you. I think that there are some implant systems that have nice stable bone, but I've seen bone loss on every single implant system that's out there.
Yeah.
I've seen bone loss on every single implant of different systems that I've placed. So I would love to think that if you use one implant system, you're not going to get bone loss, but you do.
Yes.
And I don't think it matters which one you use. I think that I like the platform switch that you automatically have to get with an internal deep steep taper.
Mm-hmm.
I like the fact that it's effectively not a septic connection, so you don't have bugs in that gap. You might not remember the bone loss down to the first thread. Bit that every implant was supposed to get, and that always kind of made me think this is really stupid because the thread is spiral. So the height of the first thread on one side of the implant is different from the height of the thread on the other side, and so how does it know where to stop and what height it's supposed to be at and all of that? It was all just a biological space away from the septic connection, as far as I could see. Mm-hmm. You were talking a little bit ago about abutments coming loose, and I'm sure that there are different torques that you torque things up to, and different machining tolerances and different loading parameters put on. But I have to say, I saw a lot of my multi-unit abutments on external Xhex Nobels coming loose. Mm-hmm. You took the bridge off and they were loose. Now, you had 12 points of rotation on those abutments, so they were easy enough to put back in the right position and tighten. But they came loose a lot. Whereas the non-indexed ankylosed abutments really just don't. They just don't come loose. And it's just as well they don't, because you never get them back in the right position because they're not indexed.
Mm-hmm. Yes. Interestingly, I was reading a paper. It was only a few weeks ago, which was talking about preload in different connection types. And one of the connections that they assessed was actually external Xhex. And this is one of the reasons why I believe is external Xhex, it can actually be a predictable connection if you use it correctly. One of the parameters that they looked at was the degree of lubrication when the abutments were actually torqued into place. And what they demonstrated is that you need a lubricant on an external Xhex implant. Now, the lubricant that I use is Blue M Gel, just because it's readily available. It's oxygenating. I haven't read into it that much, but what they demonstrated is if you don't have that lubricant and you're tightening an abutment on an external Xhex implant, the chances of you achieving appropriate preload are less than 5%. That means 95% of your cases are not going to be secure. And as soon as you lubricate that external Xhex and then torque it, all of a sudden you're talking about over 90% cases achieve the appropriate preload. And the second thing that I do is I retorque after 10 minutes. Again, I'm not saying that I don't have problems, Bill, because I have had problems. I've had screws fracture. The nice thing for me with regards to external Xhex is the connection's passive. So I've had an abutment break before, and where the screw's broken as well, and I've literally taken the crown off, and I can get an ultrasonic on the head of that screw, and because it's passive, it's out within 4 or 5 seconds. Yeah. So there are pros and cons to each and every type of implant connection. And again, it goes back to what you were saying, is using it properly.
Yeah, that is a con for the deep, steep internal taper, is if you have a fractured abutment, they can be a bugger to get out. Like the Bicon case I posted on the ADI.
Yeah.
God, that was emotional.
Any tips on getting them out? Because I've got a Bicon to take out next week. I'm thinking to myself, I don't know.
The abutment or the implant?
The implant itself.
The implant itself. So the big thing to remember with those is you can't unscrew them. So you either are trephining them out, or you are cutting a window and levering it out. Yeah.
I think I'll try the bone lid first. Might be a bit more conservative. So it's one of the aspects that I find confusing is I can see the pros and cons of a deep, steep internal connection. I can see the pros and cons of an external hex as well. Is I'm not as keen on internal hex connection. I find that it doesn't, for me, an internal hex, it doesn't really give the benefit of either. For me, it's I would prefer to either go deep, steep internal connection, or I would prefer to remain Xhex. How do you feel about internal hex, Bill? Just your standard internal hex.
It all depends on whether you are compromising the biological seal that you would get with a deep, steep taper by cutting a load of that taper out and putting a hex in instead. A hex has to have play. It has to have play, in order to be able to get it in. There's tolerance in there. Whereas a deep, steep taper will bind at some point. So provided that the hex isn't preventing a good surface area of metal to metal contact with the taper, then fine. So Ankylos didn't have an index, and then it did have an index. I like the index, but if it's a bridge and can only go on, the right way or the wrong way, then we won't use indexed abutments, because you don't need them. In fact, it makes it harder. So,
So what are your thoughts? Because and the reason why I'm asking this is I saw you posted a case not very long ago. It was about a week or so ago, where you had a lady. Was it her bicon had fractured?
Yeah, that was the one on Friday that I had a very emotional time cutting out the 3mm post.
Is there a downside to using a deep, steep internal connection in parafunctioning patients? Are you concerned that that something's going to fracture and something's going to break, or you're finding that actually it's no more problematic than other implant systems?
There are some patients who will break everything you put in them. They do. Yeah. They break everything. They will break porcelain, or they'll break abutments, or they'll break screws, or they'll break implants. They'll just break stuff. There are some patients who are just destructive. Now, we will, all of us tend to then ramp up everything that we can to make what we do as strong as possible. But they still manage to break stuff. So this lady managed to break a solid 3mm titanium alloy post. Yeah. I have no idea how. She'd broken. It's a solid piece of metal. It's not. If you think about most abutments, they have a hole through the middle of them for a screw. This is a solid titanium alloy chunk, and she managed to break it. So what do you do? It would be lovely if I could spot all of these patients before they broke everything that I put in them. But I'm not that astute. I'm not that clever. Sometimes you get patients who come to you when they've been treated by someone else with implants and broken everything, and then you go, I think this is a challenging case, and I'm not sure I'm the man for it. But it's hard when this lady, is a young lady. She's, not built like a Russian shot putter. It's her first implant. Good dentition elsewhere. Why is she breaking this? But she is. And of course, she's getting married this year, so it has to be fixed.
just to add on more pressure.
Just.
I think one of the things that I've noticed over the years is sometimes there's you can have complications. There's no rhyme or reason to it. Sometimes you get a patient where plenty of bone, good bone quality, soft tissue's great, it's a healed site, medically they're fitting well, not an old patient, and you think, oh, this is a slam dunk case. You put in the implant and the implant fails, or you get some sort of complication, and you get patients on the opposite end of the scale where you do the implant, you think to yourself, oh God, that patient's going to be back with the implant in their hand the next week, and the implant integrates absolutely fine. One of the things that really stuck with me after my visit to you a few years ago, Bill, is I asked you, I said, what should I do about failures? And your advice to me was, don't take it personally, because it happens to everybody. So I just want to reassure to anybody who's listening, failures happen to me. They're going to continue to happen to me. And I think anybody who says that they get 100% success rate, they are either placing 2 implants per year or they're lying. For me, it's that simple. It's failures can happen. And based upon that, Bill, are there any tips or tricks that you can impart when you're using a deep internal connection, which may improve success rates?
So a few things. First of all, I think it's absolutely right that people do look to themselves first when there's a failure, because it's really easy to blame everything else. The implant, they smoke, they didn't look after it, they bit on it when I told them not to. They didn't brush it like they should, all of those things. But, it was me that chose to put the implant in that person. It was me that gave them the advice on how to look after it. It's down to me. And it should be. Now, that doesn't mean to say that I've done anything wrong. One of the reasons I take surgical photos of every implant I put is because if there's a problem, you can go back.
Yeah.
And it's not evidence for if there's a litigation or anything like that, because I've never needed that yet. It's because I'm questioning myself. Did I screw up? Did I mess it up? And I've placed a few implants, and I'm fairly experienced at this. But the first thing I think of if there's a problem or a failure is, did I mess up? And so and I think that's right. And I get frustrated with people that choose to blame anything and everything else. The first thing I look at is me, and I think that's right. How do you prevent failures with deep? I don't think there's any difference from anything else, apart from the one thing that you've got with an implant that's buried is you may have to contour the bone above it in order to fit wider healing components. But then again, the number of times that I had to use a bone mill on angled external Xhex Noble Speedies to fit the components on, the abutments on, it's no different. Yeah. So I don't think there's anything special. I would say that, and I know you already do this, I think at the moment we've gone through winter where daylight hours are less, the sun's at a lower angle, so the intensity of the sun is less. People are in lockdown, so they're not going out. And when they do go out, they cover themselves up with a mask. And we're seeing more failures. I get the impression we are. Yeah. Now, I'm not saying that we're having floods of failed implants, but, if a failure rate goes from 1.5% to 3%, it's double. Yeah. And so all of my patients are getting recommended to take high dose vitamin D. And if there's a failure, I tell them they have to. Yeah,
it's the same for me, Bill. I put my patients on high dose vitamin D, and if you remember, it was about a year ago. I posted on a group on Facebook a an implant that I'd placed for a patient, which had a reasonable amount of coronal bone loss around it.
That's
the bone, it was just really diffuse around the neck. And I waited 2 months, took a PA, there was no bony infill. I waited another 2 months, took another PA, no more significant bony infill. And then I put the patients on vitamin D. And I think it was about another 6 to 8 weeks after that, complete bony infill. So I went from looking at this implant thinking I'm going to have to remove it, graft and replace it, to the site fully regenerating it, and it was purely down to that vitamin D. So it is very, very important, particularly for patients with darker skin, my skin type. Yeah. We're virtually guaranteed to have a vitamin D deficiency, and correcting that is one of the most powerful things that we can do. Bill, one of the questions that I asked Riaz, which I will ask yourself as well, because it is a trend that I'm noticing as well. I'm doing quite a lot of reading and research into the moment with regards to gut microbiome and interleukin factors and osteoimmunology. And we also know antidepressants, PPIs, they can all start to downregulate bone metabolism. And another factor that can influence that as well is psychological stress. Now, obviously, people are becoming more stressed over the years. They are taking more omeprazole. They are on antidepressants. Are you noticing a trend where patients are coming in systemically sicker and their bone quality is not as good as what it used to be a few years ago? I don't have any hard data for it. That's just a trend that I'm noticing. I'm wondering if you're noticing the same.
No, it's not something I've spotted, but it's like the frog in the boiling water. If it happens really slowly, you don't really notice it. Stress is obviously something that can affect every system in your body. If your corticosteroids are generally raised, you're effectively making yourself diabetic. And yes, stress is, things aren't normal at the moment, so everyone's a bit stressed. But what are you going to do about it? That's the new normal, so just deal with it. And if it means that you put everyone on vitamin D, if it means you leave implants a little bit longer to integrate, whatever it is that you need to do to make your system work, if you just build in more failures into your working model because you're having more failures, that's fine. Most people have no idea how many failures they have. Most people have no idea how many implants they place. I love hearing people talk about how many thousands of implants they place each year and they've never had a failure. And it's just almost always when people brag about the number of implants they place, I almost instantly, the first thing I think of is you have no idea how many implants you place. Yes. And no idea how many failures you get.
Yeah, they're ballparking and they're probably magnifying it, but they're probably magnifying the numbers that they're placing by about a factor of 10.
There is a natural human tendency to overestimate the number of implants you place and underestimate the number of failures. And until you are recording data very, very carefully and specifically and interrogating that data, you don't know. You have no idea. Mm-hmm. I think that we are certainly in places like the centers that you work in and the centers that I work in. We have a generally elderly population. You and I, we do a lot of full arches. These tend not to be patients in their 30s. They tend to be patients in their 60s and 70s, sometimes the 80s. It's rare to have a patient in their 70s who's not a polypharmacy patient. Yeah. So I kind of expect these people to have sucky bone, and you just get on and work with what you got.
Do it.
Well, what else are you going to do? Yeah, do it.
Yeah.
Do the best with it. I have to say, like you mentioned, I've treated some patients that I look back on, I go, what was I thinking? Patients that were unbelievably unwell. I mean, terrifyingly unwell, but desperate to have treatment. And I've treated them, and often they've worked just fine. And it's the other patients that you think are slam dunks, and you go, what on earth is happening here? Like you were saying about skin color, we had a really lovely chap, but really, really lovely guy who, very dapper, always beautifully dressed, bow tie, everything. A black guy who really didn't spend a lot of time outside as well. And my colleague placed 2 implants in the same site. They both failed. And then it was basically, Bill, can you help? And I had a chat with him. And the first thing that we kind of worked out was that he was desperately low in vitamin D. So I loaded him up with mega high doses of vitamin D over a decent period of time. I put an implant in, I buried it. I left it for a reasonable amount of time, 3 or 4 months. I went to uncover it. It spun. I thought, oh God, I'm going to be the next guy to do it. But it looked right. It looked right. It just spun. So I just buried it for another couple of months. Uncovered it, and it was fine. And it's loaded now, and everything's great. But it's, weird stuff goes on with people. And I haven't noticed that bone's worse. I just assume I'm treating sicker people.
So it's a similar thing in our practice. It's because we do well. At Evo, we only do full arch. Our average patient age is around 63, something like that. So these patients are coming in. Generally, they've had perio, they've had bone loss, they've got some sort of systemic issues, be it diabetes or some sort of cardiovascular issue. So these patients are compromised coming in. I do work part-time in a practice separately as well. And I am fortunate that in my practice separately, I do have the UVC chamber, which I use on all of my implants. And you can also use an alkali solution. I did a podcast on this a few weeks ago called Super Osteo Integration. And for me, that is actually a very simple way to start to tip the balance in our favor, because effectively what we're doing is we're upregulating the host response just by removing any hydrocarbon contamination off the surface of the implant. So if anybody is treating people who are a little bit sicker and you want to tip the balance in our favor, it's promoting my own podcast now. But do listen to the information on the Super Osteo Integration, because it's not a small increase in bone to implant contact ratio. For treated surface implants, you can get a bone-to-implant contact ratio of 98%. Now, the issue that I had is I couldn't find any long-term data on it, but the data that was available was like over the first 8 to 12 weeks, which is the critical point anyway. So even if you have that big ramp to start with and it slowly peters off, at least it's at that critical stage. And we're helping more patients, basically. So it's, but yes, certainly vitamin D. I also will put some of my patients, if they're a little bit sicker, on VSL3, which is a very, very strong probiotic. I personally take it as well. And again, I've been reading some papers, Bill, that I've found that a lot of the good data is not actually in dental journals, it's in medical journals. And some of the orthopedic papers suggest that giving patients very strong probiotics is so good for increasing bone density that they're considering it a preventative measure against osteoporosis. So that's how strong the link is between gut bacteria and bone mineral density. So we need to read around the subject more to understand, so that we can help these patients who are more compromised. I mean, apart from the vitamin D, is there anything else that you've come across that I can use to help my patients more?
I don't have any magic. I don't have any magic solutions. Clean surgery, quick surgery. I don't aim to be the quickest, but the less you're keeping bone uncovered, if you've got a slick team that works well together, your nurse is there suctioning. Well, you know what it's like when you've got an experienced nurse and a new nurse. It's worlds apart. Your life is either happy and smooth, or it's challenging and you're biting your tongue all the while. You know what it's like. And if you've got a nurse who keeps everything in the mouth clean, saliva free, irrigated well, I'm sure that's half the battle. But again, there are most people placing implants out there aren't implant nerds like you and me who, live for this stuff. They place 20 implants a year, and they don't have a huge surgical background. And yet most of what they do somehow manages to work. I mean, I think just the fact that we can stick a metal screw in bone and get bone to grow to it, I'm blown away by that every day I do it. I think it's amazing. Yeah. So there's no magic juice. There's no, magic graft. There's no magic anything. It's attention to detail. Paolo Marlo, I was over, God, so many years ago now, 15 years ago maybe, over in Lisbon, and he said goods easy to get. Goods anyone can get easy. Goods easy to get. Yeah. Perfect is a yawning chasm of difficulty away from good. You've got to get every single bit nailed. Yeah. And that normally takes a lot of incremental learning over a long period of time, and a good team that work with. I mean, you at Evo, me at the Implant Center, we've got an incredible team. Like you've got a laboratory on site, a big laboratory now, crazy smart people. We've got a fantastic restorative team. The nursing team are brilliant. It's just, that's what you need. You need the team. And you need just a long period of incremental learning. Yeah. And again, most people placing implants, they're the only person in the practice who places. So they've got no one to learn and bounce ideas off easily. You at Evo, me, I can walk next door and just speak to someone who's got, more experience than I do, thousands and thousands and thousands of implants under their belt, and we can, bat ideas across. The ability to do a joint clinic where you have a surgical specialist, a restorative specialist, and a chief technician is just, I'm just living the dream. It's just brilliant.
For all of our cases at Evo, on a Wednesday afternoon, we have a multidisciplinary team meeting, and in that meeting, we plan next week's cases in a very high amount of detail. So what happens at that meeting is there are 4 dentists looking at one case plus the technical team. The wealth of experience that gets, because somebody will pick up something that you've missed. And if I'm doing the surgery, I know Rudy's looked at it, I've looked at it, Vlad's looked at it, and Jess has looked at it as well, plus my technical team's looked at it. I'm much more confident going into surgery. Yeah. One of the things that really blew me away about your practice, Bill, is the on-site lab that you have is just, their attention to detail is just incredible as well. Because our lab at Evo is closed, so an external person can't send us in any work. But yours is an open lab, isn't it? So people can send in work. And obviously, when you're talking about a lab where all they do is implant work all day, every day, you start to become very, very proficient at it. So is that one of the reasons why you originally opened the lab? Because you wanted that level of control on site to make sure everything was done how you wanted it to?
It took us 5, 6, 7 years to open the laboratory, and we hated those 7 years because we didn't have control. We were using a laboratory owned, managed by someone else. We were very lucky, kind of just coming across fortuitously John Dolding, who runs it, and he is a driven person. He was a platinum Straumann technician, and all he ticked all the boxes with his training, but he's built that lab an incredible amount. We are now at the moment in the process of completely rebuilding the laboratory, massively expanding it. There's a whole load of building work going on. I'd love you to come down and see it in 9 months when everything's finished and kind of lockdown's over. And I think I might be coming up to Evo in a few weeks.
Fantastic.
But to see what you guys are doing and for us to be able to show off what we're now doing, I'm like I say, I'm living the dream every day I go in.
Yeah.
Except for today when it was really quite a tough day.
You get those days.
Oh, you do.
Yeah, absolutely.
But see, I'm lucky. I don't go into work. I don't work. I go in and I do what I love doing and I have fun and I'm learning so many new stuff, whether it's intraoral scanning and that digital side, whether it's guided surgery. I've gone from being a fairly experienced, supposedly good manual placer of implants to having to learn the basics of digital planning and digital placement, guided placement, from YouTube videos and learning it myself and spending hours and hours and hours, endless hours, learning and planning cases. And, I'm 54 now and I love learning new stuff. I love it.
Yeah, I mean, this is the level of commitment that Farhan and I were talking about as well. Because Farhan and I were talking about how to progress your implant career and mentoring. And one of the things that came across is you really need to have a passion for it, because it's very easy to get into implants just from the amount of courses that are coming out there, but is to really progress and start to hone your skills, you need to have this attitude of continued learning. And it is a lot of fun. The number of times my wife will say to me, is that the last paper you're reading? Because you've got to come down and spend a bit of time with us now. I was like, yes, I promise, last paper. Yeah. And as you said, going into work, it's fantastic. I love it. The team that I've got is just amazing. I can't imagine working it in another fashion. So it's good to hear that you've got that level of passion for it as well as I have as well.
But also, like you said, you've got the team around you. They make working easy. We've got an astonishingly good management and administrative side to my business. So although I'm one of the owners and directors of the business, it's run for me. So again, having that team just makes it possible for me to play doing implants every day.
And one of the things that again stood out for me in my trip to you is downstairs, your clinic, it's really quite calm and serene. And upstairs, where all the admin stuff goes, there were so many people there. It's the amount of team members that you had to make sure everything runs smoothly. I was significantly impressed, because my practice previously for that, it was much smaller by comparison. I didn't know practices got that big. So yeah, that was interesting.
So a lot of that's now, because of COVID and because we've had to, a lot of that is now outsourced to those same people, but at home. So we have a lot of our team working from home, but they take all the calls. So the reception team are not on the phones all day. The reception team are doing reception things. Yeah. Upstairs, all the queries are answered, all the follow-ups. That's all done for me. Even things like, organizing sedation appointments. There's a phenomenal amount of someone's got to do all the phoning around and the planning and the work. I don't do any of that. It's all done for me. And to do that, you build a team who does it. So again, they allow me to play every day doing implants.
But I'm just, I mean, we could keep going for ages. I'm just aware that we're pushing close to 50 minutes now already. I think what I'm going to do is I'm probably going to let you get back to your evening very shortly. Just before you go, I was wondering if you wouldn't mind giving just a short summary with regards to I say short summary, we've been talking about it for nearly 50 minutes. Short summary with regards to just briefly the pros and cons to the steep, deep internal implants. Just a summary for that.
Look, they don't smell. You don't need to verify impression posts. You can bury them way down deep in bone. They're mechanically strong. They're biologically nice. I like them. But all implants work if you know how to use your implant system well. And there is no magic implant system. There's no one ideal implant system. They all work if you know how to use them. That's it.
Yeah.
There's no magic.
I think it's learning the nuances of different implant systems.
Yes,
I think
that's the key thing. That's the biggest thing. So the classic thing that reps will see, all the you see from chatting to people. Someone will try an implant system. They'll place 20 or 30 of them. They'll have some problems because they don't know the nuances, and they'll say that implant system is crap. They'll buy another one. They won't bother learning the nuances. They'll place another 20 or 30. They'll have different problems, and they'll go, that's another crap system, and they'll get a third one. And that happens all the while. It takes a long while to learn the nuances of every system. And just like when you guys are planning your cases on the Wednesday afternoon, you will be doing things completely subconsciously that won't even occur to someone else. You'll just see things differently. You'll just know that something's right and something's not right. When you're doing the planning, you'll look at an X-ray or look at a CT and go, yeah, I'm not going to place it there. I just don't think it's going to be right. And and you will be right. And, when someone less experienced is looking at the same X-ray, even if you say don't place it there, and when they say why, you'll go, yeah, I don't think it's going to work there. And you might not even know, but you do know, right? Yeah. Because you've put the hours in and you've just done it over and over and over. 10,000 hours of purposeful practice. So
anybody listening is research the implant system that you want to work with, and just keep going with it. It really is a case of going through the steps, having the failures, figuring out what went wrong with it, and then and then refining your skill. For example, Bill, on that case that we were talking about earlier on today, is for me, for Southern, I know that I can place them at 100, 120 Newton centimeters. Ankylos, it's not designed to go in at that torque. You can try, but you quickly learn not to. No, but the reason why I can put the Southerns in at such a high torque is I understand how to develop the osteotomy so that there's no pressure on the neck of the implant, and I can still achieve that very high torque. I understand how the carrier feels when it's about to give. I understand that as the implant's going in. But you only learn that from breaking a lot of carriers. Yes. I've broken plenty of carriers. Then I've had to take the implants out, re-prepare the osteotomy, and then put a new implant. Yeah. And that goes down to learning the nuances of an implant system. And that's something you absolutely cannot avoid. You have to learn the nuances of an implant system. Bill, thank you so much for your time this evening. It's been great. Real pleasure. Thanks for asking me. And I really hope to see you at EVO in the next few weeks. That'd be fantastic to catch up again. And I will definitely be coming down again in the next few months once your labs. We trust me, we are going to just be sponges soaking up what you guys do. We have so much to learn from you guys. Can't wait. Yeah. And I've always got loads to learn from you as well. Bill, if anybody was interested in sending some implants to your lab, could you just remind us of the name of your lab? I'll put a link in the podcast description as well. But if anybody wanted to Google search it, what's the name of your lab? Sure, it's Ceramics Designs Laboratory. Okay, there we go. So Google that, Ceramic Designs Laboratory, CDL. Yeah, brilliant. Thank you very much, Bill. Enjoy the rest of your evening. And you, take care. Bye now. Thank you.